so today I'm going to be talking about eliminating obstacles and barriers with sex ed and wisely responding in the presence of sexual behaviors. So just a little bit about me first. I got my bachelor's in psychology in 2014. I started initially working in the field with ID populations in about 2009 as a DSP working on my undergrad. Later, once I graduated, I was a Q and ran multiple individualized supported living homes across the St. Louis area. Life happened, and later on, I decided to go on for my master's in special education with an emphasis in applied behavior analysis. Became board certified as a behavior analyst in 2023. I completed a practicum at my current place of employment, Empowered, working with sexuality. With a lot of the times we work with adults, but I have worked with some teenagers as well. And I also became a certified behavioral sexologist in earlier this year, 2025. However, I've been working in the field since I was working on my master's. So that's a little bit about me and my background. And these are our objectives today. I'm going to really have you guys applying moral and ethical framework toward general sexological principles of best practice, including autonomy, consent, self-determination, and expression. We're going to look over some recent journal articles and literature surrounding disability care settings and clinical practice pertaining to sexual and/or sociosexual behaviors and those motivations. And we're also going to gain some exposure to a framework by which we can use some skills to maybe make some ethical decisions and what to do when we see sexual behaviors at their onset, especially in contextually inappropriate settings. Right. So I just want to make it clear about your all's consent that no one's going to make you stay. You can leave at any time. You can also shut your eyes, leave the room, shift your focus elsewhere, engage in any self-care breaks that you need to. I'm not going to be judging anyone at all. Sometimes people need a breather, especially when we're talking about sexual topics, and that's okay. I understand. There might be times where I say a graphic word or describe something in graphic detail that could potentially be disturbing. I'm not, however, going to show anything pornographic or sexually explicit in nature. I may, without intent, make statements that go against your value or faith system's beliefs. But in my professional role as a behavior analyst, I am a scientist of human behavior first and foremost. And I'm striving to be respectful of other beliefs and recognize my own biases when approaching service provision. Please be respectful as well in the chat to any disagreement you have. Feel free to let those be known, but also be respectful. So we're going to go ahead and get into it after we do some verbiage. For those of you that aren't behavior analysts, just some acronyms you may see throughout the presentation. BX is going to mean behavior, R is response, SD is discriminative stimulus, which is just something that has an impact on a person because of their history with it or similar contexts. SR is going to be reinforcement, which is really just how we're increasing behavior. SP is punishment, so that's decreasing behaviors. And MO is our motivation, our motivating operation. We're going to go ahead and get into objective 1, applying that moral and ethical framework. First, we're going to start off with some operational definitions. I wouldn't be a very good behavior analyst if I didn't, have some operational definitions there. Autonomy is the right and freedom to make choices for oneself and have control over one's own behaviors. Consent and also assent are repertoire of skills that reflect asking and obtaining permission watching for body language, listening for tone, responding accordingly by only moving forward when all signs point to a clear yes. I will be mentioning infantilization as well, which is the process of treating someone significantly older, often an adult or older teen, as if they are much younger than their actual age, thereby denying them the respect, responsibilities, and autonomy appropriate for their stage in life. Self-determination is linked to autonomy and consent. It implies an individual's right and ability to make choices about desired outcomes and processes. We're trying to make sure that treatments won't violate a person's consent or assent. Expression is how one presents their internal experiences to the external world, can be through the spoken word, visual art, choices about how to dress, mannerisms, etc. Often it's a choice, but sometimes it's unintentional, such as with mannerisms. And then masking is the suppression of expression to navigate a space where expressing yourself is unwelcome or likely to be met with some sort of punisher. Also, want to hit on normativity, which is a historically cyclical and repetitive process by which the dominant population asserts itself as normal and attempts to shape all others to fit the mold through systemic assimilation. No, very wordy in the beginning. Heteronormativity is the application of normativity toward gender and sexual orientations and is an assumption that cisgender heterosexual is what is normal, not just normed. This also feeds gender stereotypes, such as expectations of sex drives. So, we must work to be understood by the individual by using common terms and abstaining from infantilization. We want to make sure that we're treating people with respect first and foremost, and maintaining the dignity of everyone we treat at all times. This means respecting their right to self-expression, so long as they're not objectively causing any harm. If you're a clinician, clients' preferences should be included whenever possible. All services should be rendered with compassion and care taken to assent and consent. That just means we shouldn't ever, even with sexual behaviors, be sneaking an intervention behind a client's back. They should always kind of know what we're doing and accept that. We should also be making sure that we talk to them about their preferences before we're engaging in any intervention specifically with sexual behaviors, because we could accidentally use something that is going against their value system. So we really want to make sure that we're identifying their preferences first. So heteronormativity and the infantilization of people with intellectual and developmental disabilities. Often these individuals are kind of left out of heteronormativity because they're victims of infantilization. They're not seen as being inherently sexual, so they're given little to no sex education and restricted access to sex and or contraceptives. Anybody here that is a behavior analyst knows that sex and sexual behaviors are an unconditioned or a primary reinforcer. So basically, it's something that our species needs to survive, so we don't have to learn that it's reinforcing, meaning that no person, even someone with an intellectual or developmental disability, is going to have no sex drive, unless, of course, they're asexual. And then since solo sex behavior is seen as weird, they can't talk about it and shouldn't do it when staff are present or when anyone is around in their own home, which for some people is always. Sometimes they always have someone in their home. So then who can they talk to? When is an appropriate time for them to be able to experience that? Also, queer expressions and behaviors are sometimes viewed as mistakes when a person has an intellectual or developmental disability due to people passing it off as them not understanding. So they're corrected often. And then we reach a point where a person is meeting a contact with a punisher for trying to be authentic. There's been a shift in ABA lately, albeit late. The BACB in 2020 updated core principles, and our core principle number 2 is to treat others with compassion, dignity, and respect. So we allow clients self-determination. They should get to choose the outcomes they want whenever possible, right? Even if they're a teenager, they should still have a say in what outcomes we're working on. We advocate for personal choice and provide resources towards desired outcomes for them. We treat all clients with dignity and equity, noting and respecting their intersections. Intersections are, some of these are listed here, your age, disability, ethnicity, gender expression or identity, immigration status, marital or relationship status, national origin, race, religion, sexual orientation, and socioeconomic status are some possible intersections. So that intersectionality is essentially anyone who is not part of the majority. We're going to look at a couple of statistics here just because I think they're important, that people should be really aware of these. Byers et al. In 2013 and Cora and Stokes in 2016 found that autistic adults around the world, at least 55%, identify as being somewhere on the LGBTQIA+ spectrum, that umbrella. Autistic adults are also 7 times more likely than their neurotypical peers to be transgender or gender nonconforming, non-binary. And they're 4 to 7 times more likely than neurotypical peers to be gay or bi. And then Strange et al. In a meta-review determined that those with autistic spectrum disorder and gender dysphoria were at the highest risk of suicide out of any comorbidity of any other population. Some of those factors that lead to suicidality are lack of an affirming environment, lack of intimate partnership, and a lack of relevant gender-related supports. So it's a pretty big deal when we're dealing with anybody with intellectual and developmental disabilities, especially in the autistic community, to be mindful that their preference might not be of the majority. And that's okay. We just need to be making sure that we're aware and we're culturally competent. We're also going to talk about microaggressions a little bit. It's a possibly unintentional, but seemingly passive aggressive and judgmental set of behaviors by which people imply through nice statements that there's something wrong with a non-heteronormative identity. Some of these things are things that parents, caregivers, or people helping out, providing support say all the time, especially when someone's a kid. I'm sure it's just a phase. I love you, just not that part of you. I can support you with everything else. If that's the choice you want to make, maybe it's just your disability that has you confused. Those are just some pretty pertinent examples. I'm sure that we've all heard at some point in time or another. Microaggressions aren't always verbal or just verbal. Overreacting to common intimacy when someone has a disability is a huge microaggression. So holding hands, kissing, dancing, I support you, but I don't want to see it. This happens a lot, especially with people with disabilities because of that infantilization piece. Also, more strict rules preventing common intimacy. Many people with supports aren't given access to sexual activity opportunities, even if they've never done anything wrong, never offended, let alone sex. But even making out can be broken up, seen as inappropriate. You know, kissing, holding hands. People might prevent this stuff just because someone has a disability, which is a microaggression. So If you intervene in a way that is indicative of heteronormative behaviors being better or right compared to a queer behavior that is anything other than illegal, per our understanding, my understanding, you're behaving unethically, technically, or immorally according to our ethics code. Heteronormative beliefs are not rooted in universally accepted science, and heteronormative behaviors may not be the best fit for a person. That's why we always need to be checking in with them. This doesn't mean that we can't teach a person to do something heteronormative. Rather, it just means that we should only do so if that's what they indicate their preference is. If they want to learn to do something that's heteronormative, then we teach them those behaviors. And the same goes for non-heteronormative. We can't just assume that they identify as LGBTQ. We want to be checking in with them. Our safest bet is to offer options and see what the humans before us choose. So some important considerations, just making this abundantly clear. ASECT in 2024 made it very, very clear that members do not engage in sexual touch, which includes the touching of breasts, genitals, a client or consumer of services in any case in which it is not within the clinical licensures established allowed methodology. And then Cicero in 2019 notes best practices for clinicians is to avoid hand-over-hand prompting for any sexual pleasure or solo sex skills. If such must occur, that should be done with great consideration, and it's best to train parents in how to do that. So never, ever, ever try to help someone achieve effective solo sex. You need to train a parent to do that. And best bet would be to get a consultation for someone who is trained in this to do that for you. The biggest takeaway here is that if you don't know what to do or don't have the answers, it's really okay to say, I don't know, but I value you, so I'm going to work to figure it out. That's a good way to remember that we should all check our biases. We should all make sure that we're aware of what our competence is and where that lies. We recognize our limits and avoid moving forward when we're not in scope, when it's beyond our role. Empowered does offer consultations, little shameless plug there. So if you ever need any help, you can reach out to one of us here. There are also, we have people countrywide that often meet with other people to help out with consults. But we also treat people in ways that are intended to help. We want to help with their well-being, such as respecting pronouns, and we get trainings on how to do this so we can do so effectively. Remembering that this stuff is actually super common. So there are so many resources out there that can help, so many trainings that can help you with how to appropriately respond when you don't really know how, especially when it comes to sexual things. Okay, we're getting into objective number 2 now. We're going to look at a little bit of literature surrounding disability care and clinical practice pertaining to some of those sexual or sociosexual behaviors. We're just going to review a couple of articles about sexuality with intellectually disabled adults. In 2017, Stein and Dillenberger addressed ethics and sexual behavior assessment. The biggest takeaway there was that we really need to determine capacity of someone to provide consent, and helping people achieve this as a goal aligned with their activities of daily living. So if you have somebody that does not have the capacity to consent to something, that's something that we should really start working on. We need to really understand what consent is. That is paramount for anything sexual. To ensure one is remaining within competency and role, we want to make sure that we know what consent looks like, maybe get a consult on how to teach consent. But Overall, informed caregivers, even people in a professional caregiver role, make the best sex educators to reduce abuse potential. Also, Griffiths et al. In 2013 talked about counterfeit deviance revisited, noting that without knowledge, rationale, and understanding of voluntariness, sex ed can't truly generalize. Okay, so most sex ed is not individualized to our learners or checked for efficacy. So what we do need to realize is that if we are going to teach sex ed, a one-size-fits-all sex ed model doesn't typically work out well. People do not remember that. Editing it and making it individualized is going to make it way more effective. But you have to make sure you're informed because uninformed people make mistakes. And rather than punishing, we want to teach and we want things to be reinforcing for a person. Gorlich, Cradle and All also talks about the differences between kink affirming and kink uninformed therapies for a complex client with paraphilia. Goals that were met across 2 years for this client. He maintained extinction of aggressive outbursts with kink affirming care. He maintained extinction of all illegal trespassing and nursery item frauding behaviors. Just in case people don't know what frauding is, nursery item frauding would be getting items from a nursery type area and rubbing it on the penis. DRA skill of doing this was his own items in his own room. So they were just using his own items to functionally replace those items he was taking and using in his own room. It increased socialization and outings for him, increased bladder control even, reduced reactivity to critical feedback by others. So he was better able to handle feedback just because of affirmation. An improvement in quality of life for the entire family per their own statements and responses to qualitative measures. So everybody was happier once they all started affirming this kink that he had. Another journal article, challenging stereotypes, sexual functioning of single adults with high functioning autism spectrum disorder. Argued the need for adequate sex ed for autistic adults, which starts when they're younger. They note the level of sexual knowledge was not an indicator of success in relationships. So it didn't matter if they didn't know anything about sex. That didn't mean they weren't going to be in a relationship, which arguably makes sex more dangerous. They weren't always able to generalize from media to real life without assistance. Autistic women are actually more apt than men to have relationships. And of the autistic men they looked at, those with gay and bi orientations had more relationships than those who were straight. The last one, they thought it was obsession. About 1/3 of autistic adults were denied affirmation of orientation on the grounds that they were just autistic and didn't really understand abstract things like gender. So the more we inform ourselves and the less we make assumptions based on what a person with autism understands, the better we can help affirm them in their identity. And when we affirm them in their identity, as seen earlier, they're going to be substantially less likely to have suicidality. Right, we're getting into our third objective now, just working out some decision making. At the onset of sexual behaviors from a person you are supporting, remember, and this is a super important distinction, that not all sexual behavior is inappropriate. Is it developmentally expected? And are you trained on what it means? Is it in an allowed time or space? Those are some questions you need to ask yourself. Like, did you walk into a room or a bathroom and you accidentally saw them doing something that you didn't want to see, then was it inappropriate or did you just not knock? If it is contextually appropriate, then is it happening in private? And if it is, there shouldn't be a concern. Is it rooted in a self-bias or preference rather than an actual need? And that's what you need to ask yourself before looking for supports and interventions. The educational focus sometimes might need to be on the person who's in distress over the behavior, not even on the identified client or individual. A lot of staff training sometimes to help out with being less rigid and checking your own bias and not forcing your values onto someone that you are supporting. When contextually inappropriate behaviors occur, we want to consider the following elements. Is everyone safe, including from legal consequence? If not, the first area of need, obviously do what you need to do to get everybody safe, right? Whatever is relevant and within your abilities, get everybody safe. Is this within my scope? So is it relevant to your role? Have you had any training specifically regarding that behavior, that population, or have you worked on a case like that before? If so, then feel free to move forward a little bit. You also want to ask yourself, though, what are your available resources? Is there time for training or research? Can you find a consultant who can help you? If you have time and it's not emergent to get them home immediately, take your time. Find those available resources so you can be as informed as possible going in. If you're not trained in sexuality, sexology, or education related field, you can still address certain things, but you need to be sure you have no biases and you're working on facts alone, not opinion. Some of those things that you're fine to address if you're not using biases, genital hygiene, showing somebody how to clean it. Things like don't use soap anywhere but the outside of the vulva, making sure that an uncircumcised male knows how to pull back their foreskin, maybe showing diagrams, things like that. Those are facts. You can totally teach those. General consent and assent education. These are a couple of curriculums here: assertive language and autonomy awareness skills. A5 is against the law, helps a little bit with some consent and assent education. Also, general public versus private education. That's really simple. It's another building block of sexual behaviors, is really identifying what is okay for the public versus what is okay for private and where those areas are. This could be done using pictures for a client that doesn't speak. It can be done as young as 3. You know, you can start teaching kiddos as young as 2, 3 years old. Where is a private place? Where can you go to get dressed? Shutting the door when you're potty training is something very simple that teaches public versus private. Also, the basics of anatomy. Always, always, always use appropriate terminology when you can for genitalia. It actually substantially decreases the likelihood that a child is going to be sexually assaulted or molested. So them just knowing those terms is a huge deal. Use the correct terminology for that basics of anatomy. And then social media and online safety. I know my coworker Megan did another presentation that was really good on social media and some online safety and porn literacy. Maybe check that one out, see what she said about it. And definitely teach, like, what information you can and cannot give out. If you're not trained for anything beyond that, you can call in an expert. Call in help if any of these behaviors show up. So public solo sex, that's masturbation in any place that isn't private. Grinding or humping of adults by a child, you might need a consult. Non-consensual touching of others, peers, minors by an adult, animals, family members, you might need a consult to come in. And it's really important for you to get consults for that and appropriately handle it pretty quickly, Because with non-consensual touching like that, if you have a 16, 17-year-old boy that has no capacity to consent and is doing this, some states, their legal systems don't care, and they can still end up being a sex offender. Expressing an identity such as LGBTQIA+, furry, kink identified that you haven't worked with prior. You may need a consult just to educate yourself on those intersections and communities so that you can appropriately handle them. In the short term, your immediate response, if a problematic sexual behavior is directed at you or another staff, avoid giving it attention as best as possible, because attention might be or become the function of that behavior, and it could make it worse. Try to use a cover story or excuse for engagement with them unrelated to the problem behavior. When they have a motivation to engage, present a basic contingency for moving into something more appropriate. Like, if you want to watch a movie with me, that's fine, but you have to have your pants on and keep them on through the movie. Or if you want to watch a TV show with me, that's awesome, but you need to sit with something between me on the couch. If the sexual behavior is directed at a peer, again, avoid giving it attention. That may or may become the function of the behavior. Use a cover story or an excuse for splitting them up, unrelated to the behavior. Like if somebody is interacting with their peer, try to get the peer pulled away and doing something else. Like, hey, look at this. Do you want to come do this with me? Get them engaged separately in two different things. After it's said and done, check on the peer, but without implying that it's been traumatic. You don't want to have a huge reaction with them, like, oh my God, are you okay? That's going to cause attention to it. And then that may incite the trauma response versus preventing it. So you want to make sure you're calm, cool, and collected when you engage on checking in with that peer. If the client, student, or learner has come out about a non-heteronormative identity, thank them for trusting you. First and foremost, thank them, because it's a big deal for someone to come out to you and trust you enough to share it with you. And affirm them for where they are, including their pronouns. If they've told you they're using they, them pronouns now, use them. Or if they've, whatever they've said, use those. Show that respect. If they want to share this with family, helping them prepare for positive and negative outcomes you can try to do with a pros and cons list potentially, but it's a time where you could also consider consultation. Working with the family to understand the realities of non-heteronormativity, because their behavior towards the individual can push toward or prevent suicide. Having supportive family members is a huge, huge deal when it comes to a teenager, especially a teenager with an intellectual disability coming out. Things a sexological consultant can help with, we can help with coming out, gender orientation navigation. We can help with ineffective solo sex, public solo sex, non-consensual sexual touch, kink identities and or behaviors, harassing and stalking behaviors, and compulsive or illegal porn viewing. I think there's somebody at our agency specifically that can help with any combination of all of these behaviors. We can also help with the teaching of general sex education through anatomy and consent, puberty, gender and sexuality orientations, flirting and harassment, relationships and progressions, sexual safety, online dating safely, and porn literacy. Sometimes before coming to a sexological consultant, though, you may need to consult with a medical doctor. Some things can appear sexual in nature, but actually be medical. Psychotropic medications can cause sexual dysfunction a lot, leading to sexual behaviors. Other medical issues that could also lead to perceived behaviors may be a UTI, a yeast infection, elevated PSA for some older guys, or ineffective release. Ineffective release just means that they're not ejaculating when they're attempting solo sex. All of these things could lead to what we assume is a sexual behavior, and the reality is a trip to a doctor can completely mitigate all of these things. Potentially, not always. Sometimes they are behaviors. One last thought before we get into our case analysis. It's okay for you not to know something or not to have all of the answers at any given moment. Rather than trying to think of something and risking biases or preconceptions coming to the forefront, you can always say, I don't know, but I care and I'm going to find out. No one's going to fault you for saying you don't know, so you can do a little bit more research. Okay. Next up, what would you do here? Jacoby is a 16-year-old male with level 3 autism spectrum disorder, non-speaking. He uses a talker with limited novel speech, primarily speaks in scripts. He is engaging in what appears to be solo sex in public settings. He's engaging in this in public areas in the home, at school, and in the community with no variation in intensity or frequency that anyone can really notice. There is a history of psychotropic medication and use due to physical aggression and SIB. Currently, he's on Abilify and clonidine, 15 milligrams of Abilify, 0.2 of clonidine. The behavior looks like him sticking his hand in his pants and aggressively tugging on his penis multiple times per day. No evidence of effective release. What would you guys do?
So I would get more information from the school or the family. I had a situation similar to this where the school was trying to figure out what to do, but they found out that at home it was okay with the family for the student to like do a behavior similar anywhere in the house, and there hadn't been any education on private versus public. So I'd start with that.
Yeah, getting all that good information is a really good call for your first step, more of an interview process for sure. Anybody else have anything they want to add?
I think I would check in with the family to see if he's actually successfully masturbating. Because just the level of frustration of not being able to release or finish can be causing that behavior to increase in frequency.
Absolutely. Okay. So no one mentioned knowing medication side effects. Knowing medication side effects. This is like my biggest area where I look very, very first when I first start working with somebody is what medications are they on? A lot of times we see people on psychotropic meds. A lot of times they have sexual side effects of some sort. Abilify side effects can include priapism, which is prolonged erection that doesn't go away on its own. Maybe that's going on and he's uncomfortable. It can also cause unusual compulsive urges, including sexual urges. That could be what's going on too. Clonidine can include decrease or loss of sexual ability, so he may not be able to finish. After you look at those side effects and you notice, hey, red light, maybe we need to talk to the parents, guardians about getting him in for a consult with the prescriber to rule out these side effects, make sure, how long has he been on these meds? Did he just have a dose increase? Are these side effect related? And also, can we check him for UTI? What if he's uncomfortable because it's burning and he can't pee, feels like he has to pee all the time? Anything medical should be ruled out first here. But while you're waiting on a medical consultation, definitely the interviews between home and school and working on him with the discrimination of public and private and consent basics. If the medications are updated and not the cause, and you still need help with how to create an intervention, get, one of us to help consult, and somebody can help you figure out what the best intervention here is. But public and private usually is like the foundational of how to really prevent that from occurring in public settings. Okay.